was asked to talk about spine, which is a good thing because that's really all I know about. I'm going to talk about sort of common lumbar issues that patients will encounter and go through the basics of the anatomy, the epidemiology, treatment sort of protocols, and so forth. And this is what we'll look at today. We'll look at the sort of just briefly discuss anatomy of the spine, which I'm sure most people are very familiar with, but just for the sake of completeness. We'll talk about disc herniation, spinal stenosis, spinal listhesis, and then everyone's favorite, low back pain. So just briefly, this is the anatomy of the sort of the spinal column. You've got the cervical, thoracic, and the button is right here. Great. All right, cool. Thoracic curvature here, and obviously we're going to be focusing down here at the lumbar area. At each level, the important thing to know here, just sort of at a high level, is that at each of the levels here, there's a nerve that leaves the canal and goes to the extremities, and in our case, for the lumbar spine, the legs, bilaterally. In the lumbar spine, the nerve that leaves is named for the bone that it goes underneath. So at the L1-2 level, it'll be the L1 nerve root that's leaving at that level. So if we zoom in here with little red boxes, we can see a little bit more detail about what we're looking at. The important structures for the lumbar spine are going to be first, obviously, the anterior and middle columns here, where the vertebral bodies are, and the discs. And the discs allow for motion to occur anteriorly between the two vertebral bodies. This, again, is a neuroforamen where the nerve exits the canal. This is the facet joint, which allows motion between the two bones posteriorly. This is just sort of a back view looking at the relative positions of these anatomic structures. If we cut away a little bit, we can see here, this is the canal where the spinal cord and in the lumbar spine, the spinal nerves run longitudinally. They go out these foramina, and these are the facet joints here. These are actual true joints and can suffer from arthritis. The discs themselves are not actually joints in the traditional sense, but they certainly go through degeneration that's conceptually similar to arthritis. And this is sort of the positioning of the nerves within the foramen and how they are positioned relative to the disc and the facet, which is relevant for when patients suffer from arthritis here or disc bulges here, and how this area where the nerves, oops, I might be speaking too slowly here too. And this is how we can sort of understand how structures can impinge upon the nerve root at this location, which is a very common place to experience nerve compression. This image here is really just here to show you where the epidural space is relative to these other structures. We know about epidural steroid injections. That's an injection in which the medication, which is typically some kind of steroid and some kind of local anesthetic, is injected into the space between the dura and the bone. This is where the epidural space is relative to the nerve root and the spinal cord. This is actually a cross-section of a cervical bone, but this is the best picture I could find. And I wasn't going to draw one because I'm not that artistic. So disc herniations. All right, let's talk about some stuff here. So disc herniations are very, very common. And I think this is probably one of the most important things to know about disc herniations, that they occur in about a third of asymptomatic individuals. And now the implication of that is that just because you have a disc herniation does not mean that it causes any kind of problems at all. So the finding of a disc herniation in of itself does not require any treatment. It's important, the most important thing is to correlate the finding with the patient's symptoms. The pain that results from disc herniations typically are sciatic, meaning they run down the length of the extremity. So in the lumbar spine, the leg. The classic symptoms for a disc herniation is pain that sort of radiates from the back down the leg into the foot. So that can be pain or numbness, or alternatively, it could be weakness in the distribution of that specific nerve. Statistics show that 1 to 2% of patients will have this in their lifetime, lasting for more than 2 weeks or more. There are a number of risk factors. It's a very complex sort of phenomenon, but things such as a sedentary lifestyle, chronic cough, smoking, frequent lifting, these are things that have been shown to be to predispose patients to having disc herniations or symptomatic disc herniations. And the highest prevalence is in this age group, sort of the middle age group that I'm quickly approaching. The good thing that we should also know is that there's a very favorable natural history, meaning that if we just let things go and just watch patients, most patients get better on their own. And I tell patients all the time, if you wait three months, there's a 90% chance that you'll feel a lot better. So surgery should never be the first, it should never be the first option in almost any case, but it should certainly be reserved for patients who fail conservative management. And that's a recurrent theme in all of spine and, well, most of orthopedics. But specific to the disc itself, knowing a little bit of the anatomy can help in terms of understanding what people talk about when they come talk about disc herniations. The disc has two general structural parts. There's the outside, there's a very fibrous, sort of thick, tough outer ring that contains this more sort of jelly-like substance in the middle that's very hydrated. Essentially, it's 70% water. It's a very avascular structure, kind of like the cartilage in your knee or your hip, so it doesn't really regenerate or repair itself very well or at all. And it's minimally innervated. So there's a concept that discs that are degenerating can be painful, and this is very controversial and is still sort of undergoing research. But we do know that the vast majority of the disc sort of within the fibrous ring is essentially not innervated. So you really can't feel pain inside your disc. Now, whether or not you can have pain fibers along the outside, especially where there's damage, that's sort of a topic for discussion. Terminology-wise, you'll hear people say disc herniation, slip disc, protrusion, extrusion. They're all kind of generally interchangeable, but when you look at radiology reports, I think most radiologists try to stick to some convention. You'll see that when they say protrusion, they really mean kind of a bulge, like you'll see here or here, where the fibrous outer ring, this annulus fibrosus, is still largely intact. And extrusion would be a rupture of this ring and basically some actual nucleus pulposus being squished out into the canal. And then a sequestration is a situation where that piece actually kind of just migrates away a little bit. So why does this happen? Well, generally, it's not really well understood. And I tell most patients that a large portion of why this happened to you is largely genetic. So it's not clear that we can necessarily modify sort of the history of your disease or your ability to prevent yourself from getting something like this by doing certain things. It does fall in the spectrum of disc degeneration, so essentially this concept of disc arthritis. It starts with drying of the disc, which then causes some collapse because you lose that sort of internal integrity. With that collapse, you can imagine the fronts and the backs of the discs will sort of pooch out, and that's what the disc bulging results from. And with progression of that, you can get rupture of the disc and so forth. And again, so genetics, age, and physical loading account for about 75% of the variation between patients. So why I get it versus you don't, you're not getting it, is going to be related to my age, genetics, and my physical loading. Again, so symptoms, so this concept of radicular pain, is very, as a spine surgeon, we really want to identify which patients have radicular type pain versus sort of non-specific back pain, because it's and as we'll talk about later, it's the radicular pain that we're more successful and reliably able to improve with surgery. So radicular pattern, again, refers to pain that sort of follows the distribution of the nerve, so it should run the entire length of the leg or largely the entire length of the leg. Why do you have symptoms? Now, there have been studies that have shown that just compressing a nerve doesn't necessarily cause pain. There's something about the chemical environment or the biology around the nerve and the specific person that sensitizes it to feel pain or feel numbness. And this is reflected by the fact that there are a lot of people who have disc herniations that are showing clear herniations on MRI who don't have any pain at all. And this is believed to be through chemical mediation, through the cytokines, sensitization, again, of the nerve because of things like the actual nucleus, which can cause the nerve to become very sensitive to being compressed. And although not all discs regress, even though some of the symptoms can resolve, there has been a positive correlation between actual identified disc regression, so resolution of the herniation, and resolution of symptoms. So how do you diagnose this? Well, a lot of it is clinical, but you can confirm this obviously these days with MRI or CT myelograms, so you're actually visualizing the discs through imaging. EMGs are very useful because they can actually, it's probably the only way you can actually do a physiologic examination of the nerve function itself. And then a lot of people will perform nerve root injections or some kind of interventional pain management procedure, both for therapeutic purposes. Clearly, we like to help the patients feel better, although it's short-lived. But for me especially, it's more of a diagnostic procedure for me to confirm the suspicion that this is the actual nerve that's causing the symptoms. If I go and ask one of the pain doctors or myself to go inject a nerve and the patient's symptoms improve, that's a pretty good simulation of what kinds of relief the patient should expect with a procedure. with a surgical procedure. So this is an example of a disc herniation, a lumbar disc herniation. Here at the L5-S1 level, you can see on the sagittal view this bulge of the disc. On this axial view, you can see this disc occupying this area of the canal. This is considered the lateral recess. On this side, this is the right side. You can see the nerve root right there sitting pretty free. And over here, you can see this nerve root is clearly within, it's displaced and clearly being compressed by this disc herniation. So how do you treat this? Now, the first, second, and third things you do for anyone with a disc herniation is non-operative. Patients who are eligible for non-operative treatment have to demonstrate an absence of other surgical emergencies. And throughout spine surgery, there are really very few of these outside of, say, trauma. But the true things that would push you towards surgery sooner would be a progressive motor deficit, or I'm sorry, progressive neurologic deficit. So someone who's developing, for example, worsening weakness in their ankle. That's something that has functional outcomes that are relatively less good than those who don't have it. So this would be a reason to potentially think about surgery sooner. The absence of cauda-equina syndrome. So cauda-equina syndrome is a situation where patients are developing loss of their control of urine or bowel function, as well as saddle anesthesia. So anesthesia kind of in their perineal region. They get numbness and tingling there. This is a sign that patients need to have decompression in a relatively urgent manner. So in the absence of that, and these are both very relatively rare phenomena, non-operative treatment is preferred. Even though it's not clear that non-operative treatment changes or alters the natural history, because of the favorable natural history and because of the just the benefits of having supportive care, non-operative treatment is largely indicated in most of these patients. So what are the favorable predictors? It's kind of jumbled. I mean, there are a lot of different things that can predict better outcomes, but in general, things like patients who are motivated physically, patients who have more than 12 years of education, non-workman's comp, normal psychological profile. So there are a lot of things that come into why patients feel pain and how they respond to their pain. It's difficult to, and knowing these favorable predictors really doesn't change how you're going to treat patients anyway. So it's kind of not sure how useful that is. But in any case, how do you start? So clearly medications are an important part of treating disc herniations. Preferred treatment with medications are with NSAIDs, but there are very few sort of controlled studies that have been used to identify which are the truly significantly preferred medications. But narcotics, oral steroids, muscle relaxants, and even anti-epileptics have been used in this situation. Physical medicine, meaning physical therapy or bed rest, they really haven't been shown to improve outcomes long term, but they're clearly part of the regimen. Bed rest should definitely be limited to about 2 to 3 days. Most of the research demonstrates. Prolonged bed rest beyond that does demonstrate worse outcomes. Other things we can do: injections. They have been demonstrated to provide short-term relief, but don't sort of demonstrate longer-term improvement of outcomes, and does not change the natural history of the disease process. Other things that people also will try in an attempt to make themselves feel better during the natural, the non-operative treatment portion of the process would be traction, manipulation, massage, acupuncture, bracing. These are things that just really have not been demonstrated to provide long-term benefit. But in that they don't make things worse, it's reasonable to try if they provide some symptomatic benefit in the short term. So in general, observation is preferred given the favorable natural history, and then epidural steroid injections for therapeutic relief is very important, but for diagnostic purposes also has an important part of in terms of the decision-making process is important. Operative management. So what are the indications for this? Again, neurologic deficits, progressive, cauda-equina syndrome, or failure of non-operative treatment. One of the important things to realize is that the size of the actual disc herniation doesn't really correlate with the need for surgery. It's, in fact, it's the larger disc herniations that tend to resorb more and are more amenable to non-operative treatment. And what is the procedure? The preferred procedure is these days a microdiscectomy. It's it's an outpatient procedure. It's pretty routine. It's a small incision. Essentially, what you're doing here with the patient prone, you're making a hole in the bone, and that in and of itself actually provides probably most of the benefit. By creating the hole in the bone, you're giving the nerve that's typically pushed up against the bone more room to breathe, so to speak. And then you're also going in and you're removing this part of the disc that's causing the compression. So when you're looking actually in the OR, this is kind of what you're seeing. But with a microscope, you're looking just basically right through here. Typically a day surgery, so patients will have their surgery at 7:30. They go home by 3 or 4 o'clock that afternoon. And the outcomes, this is the important part of sort of the literature within the spine more recently. There's been an excellent multi-center sort of prospective controlled trial that's demonstrated significant improvement with surgery compared to non-operative care at 4 years in the important sort of outcome measures of pain, function, satisfaction, and self-rated progress. So surgery does provide patients with significant benefit in the setting of the disc herniations based on current literature. Okay, spinal stenosis, another common problem faced by a lot of patients with regard to the lumbar spine. Spinal stenosis is a clinical syndrome, so there's no test to actually diagnose spinal stenosis in terms of what patients actually feel. You can certainly identify spinal stenosis on the imaging, and essentially what it means is that you're having some kind of encroachment upon the canal here, either with arthritis of the facet joint here, where you get bony enlargement. You get enlargement of the ligamentum flavum, which is a soft tissue structure that sort of sits here longitudinally along the spinal canal, or you can have a disc herniation that can occupy some space anteriorly. The natural history, luckily also very benign, generally speaking. Most patients tend to sort of stay stable for, well, with research, it shows that 4 years, most patients stay stable. The balance of those patients, half worsen, half improve. Unfortunately, you can't identify who's going to worsen, who's going to improve, and who's going to stay the same. Pathophysiology is just like disc herniations. It's more degenerative in nature. You get a drying of the disc, you lost the disc height, that disc starts to settle and bulge. You get a little bit of micro instability. So this is sort of basically taking disc herniations onto the next level. And with micro instability, because of the sort of the deflated disc, those bones will start to move against each other a little bit more. Because of the microinstability, you're going to get hypertrophy of the facet joint. If you can imagine, the facet joints in the back of the spine are going to try to resist that motion. They do that by sort of forming bone spurs, enlarging, and so forth. And because of that, you get encroachment on the spinal canal. And the typical sort of classic story that patients will give you is that, I have a difficult time with my spinal stenosis, but if I lean forward, I can actually do more and I have less pain. And that's because with relative flexion, you're actually increasing the cross-sectional area of the canal just enough to provide a little bit more blood flow to the nerves and provide them with a little bit of respite. In addition, all of these things up here can cause the neuroforamina to narrow as well, so you can get stenosis of the canal and also the little holes where the nerves exit. So you can get radicular symptoms, but also spinal stenosis symptoms, which we'll talk about right now. What are spinal stenosis symptoms? Well, certainly you can get any of these things that are that can result from nerve compression, but neurogenic claudication is the classic clinical syndrome associated with spinal stenosis, and that is essentially fatigue or pain in the buttocks and legs with walking or with activity. So the classic story for neurogenic claudication is, I can walk 50 feet reliably, but then my legs get really tired and achy like I just worked out. And that never used to happen before. I feel better if I'm walking uphill, because when you're walking uphill, you're actually leaning forward a little bit. I have no problem on a stationary bike, because on a stationary bike, you're leaning forward, you're opening up the canal a little bit. If I'm at Target and pushing around a cart, I feel good. I can walk for as long as I want. Again, because you're leaning forward, opening up the canal. This is not to be confused with vascular claudication, which is arguably a more common phenomenon. Claudication refers to essentially pain in the legs, which can result from nerves being compressed or some kind of vascular insufficiency. Now, what's the classic story with vascular claudication? Patients will say, I can walk 50 feet, but if I just stop, I can walk 50 feet, my legs get really tired. If I just stop and stand still for a little bit, I can sort of recover, it feels good again, I can walk another 50 feet. It's not affected by posture, and of course, you should expect to have some kind of vascular derangement associated with it. Now, this is spinal stenosis. You see at this level here, this is the L4-5 level. You see within the canal, there's just almost complete obliteration here on the sagittal view. On the axial view, if you'll remember, you typically expect to see a canal that's wide open here with white spinal fluid. Here in this situation, you're seeing enlargement of the facet joints. The ligamentum, which is this black structure here, is enlarged and thickened. there was a disc bulge here as well. So this is almost, we probably classify this as severe or critical stenosis at this point. But again, patients can have this amount of stenosis, and if they're not symptomatic, we're not going to do anything about it, or you shouldn't do anything about it. So there's no gold standard for diagnosing this. This is a clinical diagnosis. With regard to the imaging, MRI or CT myelogram is useful, and obviously the most important thing is to correlate with the clinical symptoms. These are the types of things that correlate most strongly with the syndrome of spinal stenosis. So patients over 65, extreme lower extremity pain, and absence of pain when seated. Indications for non-operative treatments, same thing as disc herniations. Non-operative treatment itself, almost the same thing as disc herniations. So a lot of it will be physical therapy, where we engage them for core strengthening, so core stabilization exercises, stretching education about posture and body mechanics, as well as modalities such as electrical stimulation and so forth for their symptoms. Epidural steroid injection has been shown to provide short-term benefit, but in more recent research, it has not been demonstrated to provide long-term benefit. Operative management. This is the most common surgery, spine surgery, performed in the age group above 65. Same indications as disc herniations for those who fail conservative management in the absence of caudate equina syndrome or progressive motor or progressive neurologic deficit. What's the procedure? It's a laminectomy in general, where you're going in from the back and removing the lamina to free up the canal. The lamina essentially is all the bone from behind the thecal sac, which is where the spinal fluid is contained. Cross-section view, this is probably a little bit easier to appreciate here. You're basically just unroofing the canal, removing the bone. In reality, you're doing a lot more than this. This makes it look like it's very narrow, but in reality, you're basically taking all of this away and freeing up the canal there. It's an inpatient procedure for the most part, 1 to 2 days in the hospital. For the patients who are sort of more severely, more medically complex, there's an alternative procedure, which is less invasive, can be performed essentially in about half an hour, even under local anesthesia if necessary. This is an interspinous process spacer. What you're really doing here is you're essentially imparting the small amount of flexion that patients are sort of giving themselves when they lean forward in the situation, but you're just doing it here permanently and enlarging the canal diameter by just basically jacking up the bone above under the bone beneath and creating more space without having to actually go in and do an actual surgery on the spine. So what are the outcomes? Through the same multi-center prospective controlled randomized trial that we looked at for the disc herniations, spinal stenosis surgery has been demonstrated to provide significant improvement in back pain, leg pain, function, and quality of life out to 4 years. So it's good to know that you're actually doing something useful for patients. The next thing we should talk about here is spinal listhesis. This is kind of the next level of progression within the disc degeneration spectrum. The spinal listhesis, it's a mouthful, but really all they're trying to say is that this is a situation where a bone, one of the vertebra, has moved in position, typically in the AP direction, above one of the bones below it, or the bone below it. And this is a pretty good depiction of this. So this is what we call anterior listhesis, so spinal listhesis into the anterior direction. This is of L4 on L5. There are 5 different types. The most common type in this age group would be the degenerative type, which occurs with disc degeneration, facet arthritis, and so forth, as we've discussed. So within our age group, within the degenerative population, it most commonly occurs at L4-5. Overall population incidence is 10% of patients. 10% of the population has this at any one time, so it's pretty common. Mostly people above 50, women more than men, African Americans more than Caucasians. They didn't talk about Asians, I don't know why. Natural history, the listhesis typically does not progress in most patients, and when it does progress, it doesn't go past grade 2, and we'll talk about what grade 2 is. When patients will often ask, what if I don't do anything about this? Will I hurt myself or will I get worse? Well, research shows that most patients do not worsen neurologically speaking with non-operative treatments. But those who do have claudication, again with stenosis at this level, or essentially bowel or bladder problems, do worse with non-operative treatment. Pathophysiology, this is becoming repetitive. It's the same thing as we saw before with disc degeneration and then spinal stenosis. And then now, in addition to what's happening with spinal stenosis, the microinstability becomes gross instability. So you're actually having the bone move forward under the bone below it. That can cause back pain and also more stenosis, because if you imagine, when the bones are on top of each other the way they should be, the canals are concentric. If one slips in front of it, then you're sort of narrowing the space that the nerves can actually pass through. So the symptoms, as you would expect, are giving a combination of spinal stenosis symptoms and radicular symptoms, in addition to mechanical symptoms with respect to the low back. There are some patients who have dynamic instability, meaning that when they flex forward or they flex back, that bone is actually actively moving back and forth on the bone below it. And that can clearly cause back pain. Back pain that can typically be referred to the buttocks and the posterior proximal thighs. And it can also cause significant stenosis in the spinal canal, which can lead to caudal Aquinas syndrome as well. On physical exam, you see a number of different things. Typically, patients will have a hip flexion contracture because of the orientation of their bones, as well as loss of lordosis. With very significant spinal listhesis, you actually feel a difference in the spinous processes on examination. And of course, the neurologic findings will vary based on how significant the stenosis is and how far forward it's slipped. On radiographs, the convention is that patients who demonstrate 2 millimeters or more of difference between flexion and extension is considered to be unstable. And this is the classification system, not that complex. So basically, it's graded on how far the bone has slipped on top of the bone below it. So it's basically you split the bone up below it into 4 different groups, and the grading is based on how far along those groups this bone has slipped forward. So grade 4 has slipped into the sort of beyond the front end of the bone below it, and grade 1 is just a little bit of a slip. I think this is grade 1. Grade 1 right there, yeah. Again, most patients in this age group in this process don't have slips beyond grade 2. So this is what it looks like on X-ray. You can see here this typically this point in the bone would be sitting right here. And on MRI, when the patient is actually supine, you see that this bone has slipped back a little bit relative to where it is here. Because of the slip, you can see that there's a relative amount of spinal stenosis here compared to, say, up here where there is no slip. This is a flexion extension view. I'm not sure you can see that too well, but I tried to delineate with the red line the actual difference or the actual slip distance of this L4 on L5. You can see with extension, this bone slips backwards into a more relatively normal position. On flexion, this bone slips forward. You'll just have to trust me this is the same patient, but it is. Non-operative treatment is largely the same as the other things we've talked about so far. There's an important portion of this which is physical medicine or rehab, which we emphasize sort of a flexion-based core stabilization program, which has been shown to have very good outcomes with in terms of non-operative treatment for this issue. But again, things like epidural steroid injections can provide some short-term relief, and a combined treatment to this problem, meaning interventional pain management, physical medicine, oral pain medications have provided good outcomes at 3 years. So most respond well to non-surgical management. Of course, how much of this is just natural history? How much are we just sort of occupying their time while they just get better on their own? It's hard to say. Surgical indications are the same as what we've talked about previously. And operative management essentially entails a fusion and a decompression of the spine. So typically patients will have leg pain and back pain. You'll do the laminectomy like we described before for the spinal stenosis procedure. But in addition to that, it's been shown that some kind of fusion procedure significantly improves outcome. Now, fusion doesn't have to include any hardware. You can do a non-instrumented fusion, which would basically be a fusion with some kind of bone graft that creates a solid bony bridging between the bone above to the bone below. But there are certainly indications to provide to actually include instrumentation, specifically if you have dynamic instability, like we looked at in those flexion extension views, then adding hardware clearly is beneficial. You can add hardware in the back here. This is meant to depict a pedicle screw and rod construct where the screws are drilled into the vertebral body and then connected with rods in the back on both sides. This is bone graft in the lateral gutter that at 1 year should provide bony bridging between this bone to this bone here. For some patients, doing an inner body graft is also appropriate. This is where you actually go into the disc from either the front or the back. You remove the disc entirely, and you put some kind of bone graft into this area here, so that you will achieve bony bridging at this level. You'll also do this over here too, but so you'll get bony bridging here and bony bridging here, which for some patients is appropriate. And it's debatable. There are no clear guidelines as to which fusion procedures should be done, and that has not been fully studied yet. But this is an inpatient procedure. This can vary. This is a 3-level or 2-level fusion. This can take anywhere from 4 to 6 hours, and typically requires a 3 to 5 day hospital stay. So this is a patient I did recently. I tried to find somebody who looked like this, who actually had this construct, but I couldn't, so I gave you this. This is a 2-level fusion where we had an inner body graft at this level and did not fuse this level because this was the level that was dynamically unstable. This level had stenosis and disc degeneration. You can see here that this actually may be the same patient that we looked at before, but the goal here is not to necessarily reduce the slip. It's more to stabilize it where it is. In the low-grade slips, or actually in any slips, by reducing this, you have actually some risk of entrapping the nerve root here, and reduction of the slip actually has not been shown to improve outcomes. It just prolongs surgery and adds more complications. So that has not been advocated as part of the procedure. But this would be an instrumented fusion for L4-5 spondylolisthesis, 5-1 stenosis with interbody graft at 4-5. And what we did here, in addition, is you can see sort of, maybe be able to appreciate that this is the hole, the neuroforamen, where the nerves exit. You can see here it's a little bit larger, specifically back here. That's because we removed the facet joint here and enlarged this neuroforamen as part of this procedure. This patient also had leg pain. So what are the outcomes? In the same multi-center randomized controlled prospective study, fusion for spondylolisthesis in patients who failed non-operative treatment has been associated with greater functional improvement and significantly greater pain relief at 4 years. So this is one of the reasons why we do this surgery, because we know that patients do better with fusions than without fusions when you fail non-operative treatment. All right, so everyone's favorite, low back pain. It's my favorite patient. The epidemiology is that it's very common. 40% of patients under 30 have low back pain. 88% of patients over 50 have low back pain. And I wish I could say I'm here, but I guess I'm actually here now. Or no, I'm actually in between. All right, good, never mind. I'm not accounted for in this study. The lifetime prevalence is very high, so 60 to 80% of us will have this at some point in our lives. 10% of it will be associated with sciatica, which would imply some kind of nerve compression. It is the most common cause of disability in patients less than 50 years of age, and 12% of all sick days are accountable or attributable to low back pain. Low back pain is a very mysterious thing. We don't have a good framework for thinking about back pain because we don't really understand what causes back pain. And this is a discussion I have with patients probably 8 times a day. And I think a lot of the problem that's out there is there's a lot of misinformation about back pain and what's possible in terms of treating it and what causes it. The important thing, as we sort of alluded to with the disc herniations, is that many patients report no pain even in the presence of marked degeneration on MRI, CAT scan, X-rays, and so forth. So just seeing slip discs, arthritis, disc degeneration, even spondylolisthesis does not, on MRI or X-rays, does not mean that those specific things are causing you any kind of symptoms at all. Because we know that patients who have those things on MRI or X-ray and have a lot of it can have no symptoms at all. So unfortunately, we don't have provocative tests that are reliable in terms of identifying which of those things which of those findings actually cause symptoms. And this is what leads to the difficulty in treating patients with low back pain. So which person here has low back pain? I mean, if you gave me these MRIs just to guess, I could give you, I could flip a coin and be more accurate than actually trying to guess, because it's impossible. And these are actual MRIs of patients that I've actually seen within the last month, where this patient came in with excruciating back pain, and this patient came in with a leg pain because of some sort of nerve compression at this level. Had no back pain at all. It's hard to convince patients of that, but it's true. So what is the natural history of low back pain? Well, most episodes of low back pain are short-lived and self-limiting. Most get better by 3 months. An important statistic, I think, for this population of this audience anyway, is that patients who are disabled for more than 6 months have a less than 50% return to work rate, and those who are disabled for more than 2 years almost never go back to work. So this is why at least a lot of spine surgeons will really resist the urge to keep people out of work, because there's no structural reason why you can't go back to work. It's a pain issue, and as we all know, pain is more than just physical in origin. The pathophysiology, we talked about this already in terms of disc disease. This, I think, is an underappreciated but becoming more recognized in terms of its role in back pain in particular. There have been a number of studies who've looked at this, and there are a number of psychological factors that have been associated with low back pain. Of course, this is a very difficult topic to broach with patients, but it is at least important as practitioners and managers of these patients' treatment plans that we understand that these things have an association with low back pain and may increase their symptoms in the setting of otherwise more benign physical findings. So psychological distress is predictive. This was found in a prospective study. And 77% of chronic low back pain patients have at least one lifetime psychiatric diagnosis. So what is the pathophysiology? Well, what is a potential source of pain? Well, it could be basically anything in your back, the discs, the facets, any of the neural elements, the ligaments, the fascia, the muscles. It's really difficult to say on any one patient. And the relationship between disc degeneration, which is what I think was commonly associated with low back pain, is really unclear. There are a number of things that you could do to try and identify whether or not that is actually present in a patient, but unfortunately they're not very reliable or specific, at least as of yet within the literature. There's a belief that there's an alteration in the loading and alignment due to disc degeneration that can lead to other pain generators coming into play, such as the facet joints, the ligaments, and the paraspinal musculature. So to a certain extent, some patients will have pain because they're muscle spasm, because their alignment is a little bit off, so to speak. And then you've got progressive facet joint arthritis and so forth. So there's a large, complex interplay of a lot of the structures here. So what's the history typically show? So classically speaking, pain that comes from the disc, so low back pain that we believe is coming from the disc is classically worsened by forward flexion or prolonged standing. Patients often complain of pain in rising from a bent posture, so patients will bend over and they'll walk their hands up their thighs to stand up straight again, and of course have no neurologic deficits. Facet pain is typically worsened by extension, and you may have some tenderness posteriorly. This is classic, but really not scientific in any way. It just sort of makes logical sense. So what studies do you get? You get the standard stuff. You get the x-rays. MRIs are useful for looking at the discs themselves. There have been there's been a lot of debate and study about whether or not discs can cause pain and whether or not sort of these high intensity zones, which are essentially tears in the annulus, can cause pain. Up for debate. A discogram is something that people will sometimes get as a provocative test for disc-related pain. Essentially, you inject the disc with contrast under the assumption that by increasing the pressure within the disc, you can reproduce pain. And if that pain is reproduced and actually is concordant or identical to the pain that the patient typically complains of, then this is the pain generator. Unfortunately, when you do surgery based on those results, you still get poor outcomes. So this has unfortunately not become the definitive test we were, I think, hoping would become. So this is a picture of a patient who has a degenerative disc disease at L5-S1. This is what the MRI would look like. Okay, let's talk about treatment. So non-operative treatment, which should be the treatment for most patients with low back pain, begins with education, both about the disease process as well as things such as posture, body mechanics, and the natural history. Medications are often obviously used to try and treat some of the symptoms. It's been shown that the preferred medication are the NSAIDs, which can be synergistic with the muscle relaxants. Epidural steroid injections are used for low back pain, although they're really strictly not indicated for this. Antidepressants, narcotics are narcotics are clearly things that are used as well, and perhaps more than they should, because they really haven't been shown to provide significant benefit. Activity modification is part of the treatment protocol for a short amount of time. Prolonged bed rest provides no benefit. In fact, it may worsen outcomes. The key here is that there's a fear avoidance belief that's reinforced when you tell patients to don't do that if it hurts, or you should definitely take a month off from work. And this is emerging research within the rehabilitation literature that shows that a large portion of patients' disability comes from fear avoidance, and reinforcing that with the concept that you should avoid things that hurt you in the setting of mechanical low back pain. More, I think, progressive thought is that you should work through the low back pain through concepts like a back boot camp, trying to learn how to do the things of activities of daily living while working through the pain. Passive physical therapy, such as heat or cold, often used. Massage therapy has been shown to provide some effectiveness in sort of more chronic cases of low back pain. Other treatments, exercise therapy, such as physical therapy. Unfortunately, for acute back pain, it has not been shown to provide significant effectiveness, but there are benefits with regard to mood, preventing deconditioning, increasing pain tolerance, and so forth. Physical therapy actually is probably more indicated and more successful in the patients with chronic low back pain with regard to core strengthening, restoration of motion, and body mechanics. Manipulation. So chiropractors, people often say, what do you think about chiropractors? I think chiropractors are great. I think they play an important role in spine care. The literature is still out there, has not been shown to definitively demonstrate significant improvement with chiropractic care, but then that's true for a lot of things we do. To the extent that chiropractic care is not shown to be dangerous, I tell patients, if you have the inclination and the financial resources to pursue it, absolutely, especially in the setting where you don't have a disc herniation or some kind of neural element compromise. If it's back pain, I think it's very reasonable. And in fact, there has been research that shows that short-term relief is better than placebo. And then there are actually guidelines within our government and the Canadian government that says that there is an appropriate role for chiropractic care within the short term or the acute stage of low back pain. Traction, unclear what benefit that has. Steroids are, again, used often in the treatment of back-related symptoms, and the way they operate, their mechanism of action is through stabilizing cell membranes and inhibiting some of the pathways within the protein synthesis that causes the cells become sensitized and therefore have patients feel the pain. Injections, unfortunately, have not been demonstrated to provide long-term benefit. Other things that patients often end up being diagnosed and treated with are arthroses, so braces, but there's very weak evidence for that. And for recalcitrant patients, a spinal cord stimulator, which essentially is a kind of like it sends electrical signals that kind of override what the spinal cord otherwise would be sending to the brain. This is more, I think, indicated for patients with failed back surgery or with radicular pain, but it's also used in patients with unresponsive low back pain. And then operative management, which is highly controversial, and I would argue that most data-driven spine surgeons these days would not operate on most patients with low back pain because the outcomes were so poor, and because we're unable to identify patients who will do well with spine surgery in most cases of back pain. The indications for surgery in low back pain would be that you have localized disease, so it's 1 or 2 levels rather than diffuse degenerative change in your lumbar spine. You have a failure of significant conservative management. So I tell patients, for you to be a candidate, in a situation where you have mechanical low back pain and a lot of the findings we talk about, you will have to have tried everything. You have to have tried the therapy, the chiropractor, the injections, the massage, the acupuncture, all of that. You have to have tried it 2 or 3 times. You have to understand the risk of surgery. You have to understand that, hey, I know there's a risk for surgery. I know the outcomes are poor, but I'm in such a situation now where I'm willing to take on those risks for any chance of improvement. I mean, I think that's a reasonable case for doing that. Obviously, there are strict indications there are certain situations where low back pain is operative, but I'm just speaking to just the general sort of mechanical low back pain without specific findings on imaging. And the procedures you could do, depending on where you think the pain is coming from, based on your workup, which should be pretty extensive to try and isolate as much as you can what the pain generator is either an interbody fusion through some kind of approach, either anterior, posterior, or combined. People often ask about disc replacement and whether or not that's something you can do in the lumbar spine. In general, I would say that most spine surgeons feel that the outcomes have not been demonstrated in disc replacement surgery for the lumbar spine yet to warrant sort of broad adoption. So it may be that the hardware so far is just not advanced enough or developed enough to be used. At least the data doesn't demonstrate any superior outcomes to fusion yet. So we're still waiting for that to come through as a possible alternative to some of the things we're doing now, which is essentially a fusion. The best treatments, I think it's fair to say the best treatment within the literature for low back pain remains a structured multidisciplinary rehabilitation program. Unfortunately, this is something you can't often come by because it involves psychosocial interventions, physical therapy. It's individually tailored and requires a lot of modalities and follow-up. So most areas don't have access to this kind of care, unfortunately. But despite that, I think that it's still important to try and pursue as many of these components as possible in an effort to try and to manage patients with low back pain. So in summary, and hopefully on time, with regard to disc herniation, lumbar stenosis, and spondylolisthesis, the literature supports the operative management of patients who fail 3 to 6 months of conservative management. And for low back pain, unfortunately, it still remains a difficult disease process to treat. The data suggests that the best approaches are still non-operative, and surgery, however, remains an option for the most recalcitrant and very specific cases of patients with low back pain. Thanks.